Hi, Landy. Landy. Hey, Brother Mike.
Hey, Brother Dan, how you doing?
I'm well, sir. I'm well. Can you assist us with the closing prayer, please?
Yes, no problem.
Okay. Thank you very much, Mike.
You're welcome.
All right. We'll be getting started in 2 minutes. As you know, if you've been with us before, we usually start on time. All right. Good evening to you all. We wish to extend a warm welcome to all of you who have joined us this evening on this Zoom platform. This is Pathway to a Healthier You. Pathway to a Healthier You is a ministry, a health and wellness ministry of the Highbury Park Church of Christ. We hold meetings monthly on the Zoom platform. That is the last Thursday in each month at 7:30. We have a variety of experts in the medical field. And tonight we are blessed to have our dear sister, Dr. Raquel Peter-Curry, to present to us on the subject of cancer. Let's talk about cancer. And so without further ado, I will invite our brother Joey Folks to open us in a word of prayer at this time.
Good afternoon, everybody. Let's pray. Gracious Eternal Father, we thank you, O Lord, for bringing us through another day. May you get the honor and the glory from our gathering this afternoon to discuss health issues. Father, forgive us of our sins. Father, bless us with provision for proper food and medicines, O Lord, that we would overcome each day and our daily challenges spiritually as well. Father, bless us with peace and fill us with hope. Father, we bring our government before you as well. Father, they would lead with wisdom and with knowledge and compassion for our poor among us. Father, bless those teaching tonight. and the organizers and all those taking part. Help us, O Lord, that we would use this knowledge to better our health and to keep us, Father. For we know most of all, Father, it's ultimately you, O God, who grants us full health. Father, bless this evening's proceedings in Jesus' name. Amen.
Amen.
All right, as I would have said earlier, our presenter tonight is Dr. Raquel Peter Curry. And I would ask Dr. Curry to let us know a little about yourself before you get started with your presentation, as we have quite a bit of visitors on the site right now. And so, Sister Curry, I will turn over to you.
Okay, good night. Thank you, Brother Dean. My name is Dr. Raquel Pitacurry. I am a pediatrician who practiced in the public sector, but is now practicing in the private sector. And I'm sharing screen. Okay. And I have been doing these installments of Pathway to a Healthier You. And I am pleased to be your host again tonight. All right. Tonight, we're going to be talking about cancer. This is going to be part 1 of a 3-part series. And this session here is basically just going to focus on cancer as a general concept. In the other 2 sessions, I hope to have discussions on prostate cancer and breast cancer, which are the most common cancers affecting our Bahamian men and women, respectively. Tonight, we're going to go through some definitions, some important definitions. We're going to talk about the global and local impact of cancer. We're going to discuss what are some of the symptoms, what are risk factors, can we prevent it, how do we prevent it? We're going to talk about screening, and then for those of you who've been given the diagnosis of cancer, we're going to talk about after the diagnosis. All right, so what is cancer? Let's start with tumor. I know you've heard both the word tumor and cancer, and I know sometimes people use them synonymously, but they're not. A tumor is just used to describe a group of cells that's growing more than they should. Now, as you remember from your high school biology, the cell is the basic unit of the organism. Group of cells form tissues to form organs to work together for the benefit of the organism. Now, cells grow and cells divide. When I say cells grow, I meant that they actually grow in numbers, because as the organism grows, they're growing because the cells are growing in numbers and not necessarily in size. But all of this process governing how cells grow and how cells divide is governed by an orderly fashion. So you have new cells being formed, old cells dying off. There are signals in the cells that tell it, okay, that's enough, you stop now. And there are signals that tell it when that it needs to start to grow. So when you have a tumor, you're just having those cells, they're growing more than they should. Now, it can happen in a way that causes cancer, or it could not. You may have heard your doctor talk about it's a tumor, it's not cancer, it's benign. So what that means is that, yes, the cells are growing abnormally, but the way they're growing, they haven't invaded beyond the tissue, beyond the area where they started dividing. So there's very little chance that they're going to break off and go someplace else in the body. Now, can they cause problem? Yes, because if they grow too big, they can press on different areas of the body, different organs of the body. So think about a fibroid. A fibroid is a tumor. It's not a cancer, but it causes problems, all right? Cancer, on the other hand, is a tumor that's growing very chaotically. And so these cells now can actually grow through the tissue. They can grow into the vessels, they can break off, and they can go to different parts of the body. So this cancer is like the benign tumor on steroids. So when your doctor talk about benign versus malignant, the cancer is the malignant one, and it comes from the Latin word that has the same root word as malign. You know, that's a bad thing. So the malignant tumor or the cancer, they're one and the same thing. Now, I've searched high and low for a video to try to illustrate what happens with cancer. This came close, but it's not perfect. But just pay attention for me, please. So, as I mentioned before, the body is made up of different organs that were formed by tissues that were formed by cells. So here you see the body, and they're stripping away the skin to show you the muscle, all right? And now they're showing you the organs that's actually inside the abdomen. And now you can see from the intestines, you see in the cells, this is the orderly process. The cells are dividing, that one died, this one came in, that's the way it's supposed to be. And these signals are given by the nucleus inside the cell. The nucleus holds the DNA that tells the cells when to produce the proteins, that tells the cells when it's time to grow, that tells the cells when it starts to stop. With cancer, you see here, these cells are just going crazy. They're invading into the blood vessel because they're not listening to the cell. They're not listening to the signals. A piece is broken off and it's going now to an area taken in the bloodstream. The blood goes everywhere, and that's called metastases. So you see now that it's also, this stomach cancer has gone to the liver, and it's also in the intestine. So that's basically what happens with cancer. Okay, all right, so how important is it? Oh, and what I forgot to mention is that cancer itself is a term that encompasses a number of different diseases, so to speak. They all have the same underlying causes. But as you can imagine, there are trillions and trillions of different cells inside the body, and there are over 100, some people say over 200 different types of cancer, because each of the different areas can lead to abnormal growth, which can cause cancer. When cancer is named, it's actually named for the part of the body where it started. So if you have that abnormal growth, that chaotic growth happening in the breast, then that's called breast cancer. Even if a piece breaks off and goes to the brain and starts growing in the brain, it's called metastatic breast cancer. Remember, metastases was when a piece broke off and went somewhere else because it was carried in the bloodstream, and the blood goes everywhere in the body. So the cancer can metastasize to any place, all right? But it's always named for the area where it started. Now, cancer is the leading cause of death worldwide. In 2020, it was estimated to account for 10 million deaths, and that was 1 in 6 of all deaths globally. In the United States, it's estimated that in 2021, there would be almost 2 million new diagnoses of cancer. Not only does it affect the length of life, your quality of life, there's also an economic toll to it. And in 2010, when they did a survey, they found out that cancer cost $1.16 trillion in terms of diagnosis, in terms of treatment, in terms of support services, and that number has been increasing. So cancer has a significant impact globally. All right, so this is an analysis of data that was collected by the National Cancer Registry. Let me see if I can move this. Okay. All right, great. So what we see here, it tried to, based on data collected, it tried to estimate your risk of developing cancer. And this, again, is in the United States. So this is for Americans. So what they found is that from birth to when you get into your older age years, your risk of cancer actually increases. Now, remember we talked about the DNA in the nucleus giving the signals for cell division and telling the cells when it's okay to divide and when they should stop. Well, what happens is during your lifetime, you have more exposure to things that actually cause damage to the DNA. When you have damage to the DNA, what happens is that its instructions are off. And so sometimes when the instructions are off, then the genes that tell the cells to start dividing, they may go crazy and tell it to divide more, or the genes that tell the cells to stop dividing may go crazy and not tell the cells to stop dividing. Sometimes what happens is an accumulation of the damage that actually caused these genes to go berserk. So the longer you live, then the more exposure you have to these, the more accumulation of the damages to the DNA you have, so the more likely it is for you to have cancer. You will see here that in these columns here, it's divided by age interval. So you have birth to 49 years, 50 to 59, 60 to 69, 70 and older. By the time you reach 70 and older, this top row here is your estimated or your probability of getting cancer based on all sites available. Each different site where you can get cancer, you have different risks, different probabilities of getting cancer in that site. But overall, by the time you're 70 and older, your risk of getting cancer is 1 in 3. And if you're a male and if you're a female, it's 1 in 4. All right. And birth to death. And I guess this would, I'm not quite sure why the birth to death is different, why their analyses yield different results, but birth to death just means your overall lifetime risk. So your chance of having cancer from the time you're born to the time you die when you're a male living in the United States is 1 in 2. And if you're female, it's 1 in 3. All right. Now, I know I said that the older you get, the more likely you are to have cancer. That's not to say that cancer does not happen in young children. It does, unfortunately, but it does not occur as often as it does in older people. Now, the other thing I want to point out from this slide is that for breast cancer and for prostate cancer, your overall lifetime risk, if you're female and living in the United States, of getting breast cancer is 1 in 8. And for prostate cancer, it's also 1 in 8. All right. And if you look at these numbers here, based on the cancers that are listed, you seem to have a higher incidence of a higher risk, if you're female, of developing breast cancer than any other cancer type, and male prostate cancer, which has changed because lung cancer used to be the most common. Now, for our local statistics, for us, now it's 2021, yes, but this was a projection. So this isn't the final set of data. This was a projection based on what has been going on in previous years. It was estimated that 433 males last year would have been diagnosed with cancer. So that would have been a new diagnosis, and 443 females. So in total, that would have been 876. And you can see our population right there at the census that was done, the last one that they reviewed there. Now, in terms of cancer death, you can see that it's almost half, 467 of people are going to die of cancer. Were projected to die of cancer in 2020. And again, looking at our statistics, prostate is the most common type of cancer in males, and breast, the most common type of cancer. And your risk of dying from cancer before the age of 75 years for us. Now, this is different from the risk of actually developing cancer that you saw with the United States statistics on the slide prior. In males is 11.2%, and for females is 10.6%. Okay, so this slide here just illustrates the projected number of new cases of cancer in 2020. So of all the cases that were projected to be diagnosed in 2020, for males, prostate cancer would have been the most common at 46.4%, followed by colorectal cancer at 9.5%. This here is just a compilation of all the other types of cancers. Remember, we said you could have over 100, 200 different types of cancer. In females, breast cancer came in first at 37.5%, with uterine cancer coming in second at 12.4%. And then you have your cervix, your cancer of the cervix at 8.8%. All right, so let's talk about the symptoms of cancer. Now remember, cancer refers to a whole lot of different diseases. So of course, you won't just have just one symptom that's going to be common to everything. Now, I must say though, in its early stages, cancer will most likely be symptomatic, completely symptomatic. All right, but as it grows, when it presses on different organ system or when it invades the organ so much that the organ no longer functions, or when it starts to absorb all of the nutrients, that's when you start to get symptoms. So keep that in mind, that symptoms are actually a later development. And in the early phases, cancer is, for the most part, asymptomatic. Now, the type of symptoms that you're going to have, obviously going to depend on where your cancer is. All right. So if you have cancer of the blood, and that would include the cells that travel in the blood, which don't usually go in the blood, it starts in the bone marrow. But if you have cancer that affect those cells, if it's the cells that are responsible for clotting, there are some cells that travel in your blood that when you get a cut, the reason you don't bleed to death is because they clump together and start to clot, then you will have bleeding. You can also have bruising because that's just bleeding underneath the skin. And then the small rash, the small red purple spots, again, that's because of the dysfunction of those clotting cells. If you have cancer, because remember, when cancer starts to invade the cells and the tissue, they no longer function the way they're supposed to. If you have cancer inside your skull, if you have brain cancer, then you can have headaches, persistent headaches that won't go away. You can have seizures. You can have changes in your behavior depending on what area of the brain the cancer is growing on. You could also have changes in the way your face looks. So, you know, like when you have a stroke, you could have an asymmetrical face. When you smile, it's lopsided. Well, you can have cancer growing in those same areas of the brain that can stroke. So you can develop that as well. You can also have vomiting if you have cancer of your brain, simply because the skull is a closed compartment and you really don't have any space for anything else to grow. So when you start to have things expanding inside there, that press on the area of the brain that is involved with vomiting, and you have a lot of pressure and you start to vomit. If you have cancer in your spine, you can end up with back pain or bony pain that doesn't go away. If you have cancer in any area of your body that's close to the skin, then you can have a lump, or you can have a firmness, or you can have the swelling along that area. If you have cancer in your lungs, you can start having shortness of breath. You can actually be coughing up blood. If you have cancer anywhere along the urinary tract, which if you remember from your high school biology, that's the kidneys, the tubes that lead from the kidneys to the bladder, the tube that leads from the bladder to the opening, then you can actually have blood in your urine. And with guys, if there's cancer in the prostate, you can also have problems passing urine, because remember, you're having chaotic growth there, and the prostate lies right behind that, and it can actually press on it and cause you to not be able to pee. If you have cancer inside your abdominal cavity or belly, you can have pain there. You can have swelling. You can have loss of appetite. Again, you could have vomiting, because when the cancer compresses on your gut, the food doesn't go through, so it stays there. So you bring it back up. You could have blood in your stools. Remember also that cancer is growing fast, and anything that grows fast requires a lot of nutrient at the expense of your other tissues, meaning basically that cancer takes all of your energy. So you can have weight loss because the other tissues are being deprived of that energy, so they can't grow. And you can also have fatigue. So it is right, feeling tired all the time. So you can have it right here, feeling tired all the time. I mentioned some of the blood cells that cancer can come in. So besides the one that is responsible for clotting, you also have blood cells that act as the soldiers of the body and prevent infection. So if they're affected, then you can have frequent infections. Also, you have cells that are responsible for getting oxygen around to the rest of your body. If they're affected, then you can also get short of breath as well, because you won't be able to get oxygen around the body. And you'll also look pale, because that's actually what gives you the redness. So in summary, your symptoms will be based on where your cancer is. All right, so let's talk about risk factors. So your risk factors for cancers will depend on who you are, it will depend on what you were exposed to, and it will depend on what you do. So let's talk about who you are. So the main risk factors based on who you are would be your family. So if you have a history of cancer in your family, then you're at risk of having cancer, simply because some of those damages to genes that we call mutations can be inherited. All right. So your family history of cancer is an important risk factor. Also, your gender. All right. As we saw there on our previous slides, males tend to get cancer more than females. And of course, there's certain type of cancer that only occur in males. For instance, your prostate cancer. And there's certain type of cancer that only occur in females. For instance, your uterine and your ovarian cancer. Now, breast cancer, even though it's far more common in females, it does occur in males as well. And then your age, as we mentioned before, the older you are, the higher you are at risk of getting cancer. What you're exposed to, so environmental factors would include radiation. So that will be your UV light from the sun, radiation from medical procedures. CT scan carries a small risk of radiation. And the risk is cumulative. So the more CT scans you have, the more the radiation adds up. Now, granted, it is a very small risk, but it's a risk nonetheless. And then, of course, environmental pollution, things like smoke and smog can actually lead to lung cancer. Arsenic in the water can lead to bladder cancer. So what you're exposed to can also increase your risk of cancer. And then, of course, your lifestyle changes. Now, I started with the individual environment at the beginning, but these actually account for the highest cancer risk. All right, and then on not the next slide, but the slide after that, we're going to see how much attributable risk that cancer actually has that smoking actually has to cancer in the United States. Your diet as well, lack of fruits and vegetables, that's a high risk. That's processed meats, ham, bacon, that's a high risk. Red meat, that's also a high risk. And you would see a common thread throughout these sessions that, there are risks that you can actually change, like your lifestyle risks. There are things that you can't bother with, right? You can't change your family. You can't really change your gender, although some would have us to believe nowadays that you can, but you really can't because that's actually in your DNA. And you can't really change your age. But there are some things that you can change. You can try to limit your environmental exposure, although that doesn't depend as much on you. Because if you live in a city where there's a high level of pollution, then you live in a city where there's a high level of pollution. Of course, if you're living in an apartment where someone smokes a lot, then you can always try to move. So you can adjust it to some extent, but not as much as you can do with your lifestyle changes. So the lifestyle risk factors, these are actually the more modifiable one. But as you can see, when we go to that 2 slides from here, you will see that smoking actually confers the highest risk for cancer, even more than your family and your gender. And then physical inactivity, again, that confers a risk because exercise actually reduces inflammation. Exercise actually helps with your immune response because your immune cells are actually supposed to go around and see which cells have damaged DNA and try to clean them up. And your immune system actually helps with some of those proteins that regulate the growth of cells. Alcohol has been implicated in liver cancer. All right, and infections, I guess this can be under exposures as well, but I just wanted to put it under a separate heading. So there are several viruses and bacteria that actually increase your risk of cancer. So you have HPV, which is notorious for cervical cancer. This is a virus that lives in the genital tract, both females and males. Is responsible for cervical cancer, can cause anal cancer, can cause vaginal cancer, can cause vulval cancer, can cause penile cancer. Cervical cancer is the biggest of these. The others occur in small amounts. And also, it also causes warts. Warts, although they're not very attractive, they outside of their parents, they usually don't cause anything. For women, if you have warts when you're about to give birth, if there's a lot of warts, then they may opt to give you a C-section because it can cause problems with the baby because they can get the HPV on the passage through the tract, and they could actually develop these warts inside their nasal passages, which may interfere with breathing. Sorry. All right, HBV. This is the hepatitis B virus. Hepatitis C virus as well can cause cancer. I should have included that in there. Both of these are viruses. It's called hepatitis because it affects the liver. Now, in most healthy people, hepatitis B is a transient illness, and most people are able to clear it. When you initially get infected, you may have yellowing of your eyes, you may have some vomiting, some diarrhea, feeling very tired. The doctors might tell you that your liver is a little bit enlarged, but like I said, most people recover from it. However, in a small amount of people, the infection stays around, and that's more likely to happen if you're a very young infant or if you have a condition which interferes with your immunity. And when that stays around, that can actually cause cirrhosis of the liver, where all of the cells just become, rather than being functional cells, they really just become fibrous tissue, meaning that they're scar tissue, and so the liver is not really functioning. But it can also cause liver cancer. All right, so that's for HBV and HCV. So HBV is hepatitis B virus, HCV is hepatitis C virus, and they're transmitted actually sexually or through the exchange of body fluids. So that is one of the viruses that they will test for when you donate blood, because they don't want to give it to anybody. Because remember, it's immunocompromised people who usually end up having the worst outcomes from HPV virus. But when you're giving blood, you're usually giving blood to very sick people. HPV, I didn't mention this, but that's a sexually transmitted disease. Again, it can be transmitted when a baby's passing through the mother's passage during birth if she has active lesions, but for the most part, it's a sexually transmitted virus. EBV, or Epstein-Barr virus, that's the virus that they call the kissing virus or the kissing sickness. This virus, this sickness usually happens in adolescence, and you get it from the exchange of saliva, the hence kissing sickness. Again, usually cause mild illnesses. So you may have sore throat, you may have some swelling in your, some lumps in your neck, which are basically just the lymph nodes swelling up. You may have some yellowing of the eyes because it can also affect the liver. You may have an enlargement of the liver. So your doctor may examine you and say your liver is a little bit larger than normal. Can also cause the spleen to go bigger. But again, in most healthy individuals, it's a transient infection, and people tend to recover. HIV can cause cancers based on its effect on the immune system. So HIV, human immunodeficiency virus, it damages the immune system. And so you end up getting a lot of diseases that you would have been able to clear quickly when you're well. All right, so HIV is also a big risk factor for cancer. Now, H. pylori is the lone bacteria on this list. That's Helicobacter pylori. This is the virus that's implicated in stomach ulcers. So you would know that if you got a diagnosis of your doctor strongly suspected that you had ulcers, they would give you medication not only for the ulcers, but for the bacteria. All right, because if the bacteria hang around for a long time, it makes changes to the stomach that can actually lead to cancer later on. All right, so here on the slide, these are most of them modifiable. Ultraviolet radiation, it is modifiable. There was a campaign to increase the awareness of the problem with ultraviolet light. It causes skin cancer. And there was a campaign to promote the use of sunscreens, and they've seen a decrease in the number of skin cancers based on that. So that's a modifiable risk factor. But we see here that tobacco smoking actually confers the highest risk for cancers in people over 30 years of age. So that's almost 20%. All right. All right. Can I prevent it? All right, so 30 to 50% of cancers can be prevented, according to the World Health Organization. When the American Association, the Cancer Registry, did their progress report, they found that, and this is in 2014, they found that 40% of the cancers occurred from modifiable risk factors, means that these are factors that people could have done to prevent cancer. Okay, so here we have a graph just illustrating the amount of cancers that can be prevented just if the modifiable risk factors were modified, okay? So here we have cervical cancer. You can see that's 100%, oh, sorry. Preventable, all right? And that's because of the HPV vaccine that we'll talk about later. So cervical cancer has been almost exclusively associated with HPV, and there's a vaccine that can prevent it. For mesothelioma, if you watch a lot of TV, you may have heard it on the commercials with the lawyer, because they're always asking if you're suffering from mesothelioma, come and we'll represent you. It's basically a cancer of the lining of the lungs mostly. It can happen in other organs with the tissue that lines the organs, because the organs all have tissue that lines them. But it's most commonly in the lungs, and it's been associated with environmental toxins. So yeah, asbestos. And so that's why the law company are calling on you, because they're saying, hey, these companies should have known that. So they didn't do anything. You inhaled it and now you have cancer. It's not fair. Come, we'll represent you. Of course, they get most of the money, but that's the rationale behind it. Tracheal bronchus and lung cancer, 84.1%, because tobacco smoking is implicated in that. So not only you smoking, but if you are around someone who's smoking, especially if you're in front of them in the direct path, because when they're blowing that out, then you're actually at risk for developing cancer. So that is easily modifiable. Other cancers of the head, neck, and throat, these cancers here, these are also variable preventable, because again, smoking, chewing tobacco, these are all big risk factors for these cancers. Colon and rectum cancer, 53.2%. So as we go down the list, you'll see how they become less and less preventable. But by the time you get here, this is 53.2% preventable, and that would include your diet. So that's a big thing with colon and rectal cancer, your diet. Of course, colon and rectal cancers are also common in people with a family history of polyps. So you may not be able to prevent that. You can undergo surveillance to monitor it and act early, but that part of it is not totally preventable. And so we go on with them until we come down to prostate cancer, where it's only 4.4%. And then we have testicular cancer, brain and nervous system cancer, and malignant skin melanoma that did not seem to change when you modified your risk. Now, I know we talked about UV light and we talked about sunblock, and they've had an effect on different types of cancer, like the basal cell carcinoma, but with the malignant skin melanoma, the use of sunscreen did not seem to reduce the incidence. All right, so for prevention strategies, you work on factors you can control. So we said already that you cannot control everything, right? So you work on the factors that you can control. And just to remind you, these are the factors that you can control, all right? So you want to, if you smoke, you want to stop. If you have excess body weight, I know you've heard all the information out about obesity and inflammation. Not only that, but people who tend to have excess body weight tend to be the people who are relatively inactive and who don't pay proper attention to their nutrition. And also, they've found that excess body weight interferes with insulin. There are some studies going on now to see if insulin is actually connected to cancer. They found that people with cancer tend to have higher levels of insulin, but they don't know now if there's a direct connection. And then, of course, alcohol. If you drink, don't start. If you do drink, then you drink in moderation. 1 drink per day for women, 2 for men. Ultraviolet radiation, proper diet, and then the infections. We'll talk about this later, and then physical inactivity. So the things that you can control, you control. All right, so other cancer prevention strategies. So you can try to find precancerous conditions early, like for instance, pap smear. So pap smear, this is a screening. It can help you prevent cancer by finding precancerous conditions early, but it can also help you with the treatment of cancer, because if you find the cancer early, precancerous conditions are conditions that lead to cancer, but are not cancer as yet. So that's when they can tell that, hey, something's wrong with these cells. They're not growing up normally, but something's wrong with them. And if we continue to leave them the way they are, they're going to start growing up normally. So when you do your pap smear yearly, they can tell, they can look and see and say, hey, you might hear them say, this is dysplastic, or it's carcinoma in situ. And so you know that, hey, you need to get rid of that area there. And then there are risk-reducing surgeries. And this, remember, this is cancer prevention strategy. So several years back, a major celebrity made news when she decided to get a prophylactic mastectomy because her mommy had died from breast cancer. And people with the breast cancer gene, well, they found that most of those people will develop breast cancer at some point. So rather than waiting for the cancer to appear and then trying to treat it, some people advocate that you go ahead and you have your surgery early. But it's not just breast, because that gene is also associated with ovarian cancer. So some people just go ahead and get their breast removed and their ovaries removed even before they're diagnosed with cancer, just because they know that they have these genes and chances are they are going to get cancer sooner rather than later. All right. And chemo prevention. Now, chemo prevention is administrations of drugs or other biologics to try to prevent cancer. So these would be given in high-risk groups. I've listed here vaccines, but it's not only vaccines. They've got some other drugs available that they can give to try to prevent cancer in high-risk groups. So what we do give here in the Bahamas is the Hpv vaccine and the Hbv vaccine. Now, the Hepatitis B vaccine, which is the Hbv vaccine, that's given during infancy. So from your 2 months of age here, you get your first dose. In some countries, you get your first dose at birth. All right, but we give it to you when you're 2 months of age, unless, of course, your mommy had been exposed or had hepatitis during the pregnancy. Then you would get a dose at birth, and you would also get what we call an immunoglobulin, which is something that just fights it off until you can make your own antibodies. So they're kind of like artificial antibodies. So, because remember, babies, they tend to not be able to clear the hepatitis B virus as easily as older people. And not only that, they would have had it long in their system, so then they would be more at risk of getting cancer of the liver. The HPV vaccine, we only recently started vaccinating our population against that. And that's actually it's given to males and females. And it's given, your first dose is given between 10 and 12 years of age. And if you start before you're 15, then you only need 2 doses. But if you start after you're 15, then you get 3 doses. Now, remember that HPV is sexually transmitted, and you may be saying, well, why would you want to give my 10 or 12-year-old HPV vaccine? They're not sexually they're not sexually active. But the whole point is to try to give them the vaccine before they're exposed to HPV. All right. So by the time they're 18, a significant proportion of teenagers have already been sexually exposed. You may not know that, but the young children out there are having sex. So you want to get that on board before they start, because it really doesn't help after you've been exposed to the virus. So it helps to prevent it before exposure. So some countries give it up to 26 years of age. Some people give it up to 45 years of age. But usually by the time you're in your mid to late 20s, you've already been exposed. And so it really doesn't help. All right, so we said, according to the World Health Organization, that 30 to 50% of the cancers were preventable, which means 50 to 70% aren't preventable. So what do you do about the cancers you cannot prevent? All right, so you continue protective lifestyle changes, all right? Not only do they help with chronic diseases, they help with the cancers that you can prevent, but also if you do get cancer, you actually have a better outcome when you have these protective lifestyle changes. That's why they call them protective. So you continue with those, even if you're at risk for cancer that you cannot prevent. And then the other important thing for you would be screening. And screening is just some examination to try to detect the cancerous changes early before they dig deep through the tissue and before they spread to other areas, because the earlier you can start your treatment, then the better your chances are. So if you're at risk for something, then you should be screened for it. Now, in terms of our national cancer screening program, we do cervical cancer screening, and that's in pap smear for those 21 years and older. The reason why is because it takes a while for those changes to come about. Yeah, we have children becoming sexually active in their teenage years, but it's going to take a few years before those changes start to come about. So you can start screening at 21 years and older. And the screening is basically done every year. But if you've had 3 negative tests and you're not currently sexually active, then you and your doctor can discuss lengthening the interval time. Perhaps you can do it every 2 years, perhaps every 3 years, but that has to be an individual decision made with you and your doctor. And then for breast cancer, because we saw that breast cancer was our #1 cancer, it's recommended that you do self-exam monthly. For part 3 of this cancer series, I want to talk about breast cancer. And so I'm not going to go into the self-exam, but it's something that you should do monthly. And then mammography, your mammogram, it's recommended that you take that annually in those at least 40 years of age. And the reason that it's recommended for people 40 years of age and older is just because the young breast is so dense that you will see a lot of stuff. And of course, the screening doesn't come without its side effects. And one of them is psychological anxiety and a lot of other exams if you get a false positive. So because if you're younger and you likely will have dense breasts, so you can get anxious when they find these things, it's recommended that it start at or over 40. Not only that, but they found that our incidence of breast cancer peaks after that age group. Now, granted, does that mean that you won't get cancer if you're not yet 40? No, it does not mean that. And if you have risk factors for having breast cancer, if you have a first degree relative, that is a mommy, sister, daughter with breast cancer, then yeah, you're actually supposed to start your screening 10 years before they were diagnosed. But if you're younger than 40, then what they recommend is that you go ahead and you screen with the ultrasound scan. All right, again, on our National Cancer Screening Program is prostate cancer screening. And for us, that's recommended when you're at least 45 years of age. Now, not all countries do a prostate cancer screening. It consists of a prostate-specific antigen. And when it's high, it seems to suggest that you have cancer. But again, that's not the only reason why it can be high. It can be high if you have what they call benign prostatic hyperplasia, meaning that your prostate is growing, the muscles in it's growing, but it's not cancerous. You can have that. If you have an infection of the prostate, that can cause it to be high. So they feel that the risk isn't worth it. In our program, it's recommended that the PSA be combined with a digital rectal examination. I know you guys are going to cringe, but that's where the doctor actually puts his finger in your rectum to try to feel your prostate, because the prostate is right in front of the rectum. So if they stretch through the skin of the rectum, they can get an idea of how it feels. And that would give them a better idea of what's going on with your prostate. But probably want to do prostate cancer next month. So I'm not going to go into that anymore. Testicular cancer screening, and that's for males between age 15 to 40 years of age, simply because the cancer, although rare, it usually occurred in the age group between 15 and 35 years. So it makes sense that you would screen during those years. And that too, that like the breast examination is a monthly examination. So I have some instructions here for how you can go about screening for that. Sorry. Right. So the first thing is that you should perform it during or after warm.
Dr. Curry, can you unmute your mic, please? I had to mute everyone.
Yeah, there we go. Okay, I've done it. All right. Okay, so I was on the testicular self-examination. I was saying that for you guys, it should be performed during or after a warm shower, simply because bathing with warm water stretches the scrotal skin and makes it easier for you to be able to palpate or to feel the testes. You're going to check it one testicle at a time. And before you do, obviously, you're going to have to move the penis out of the way. So I have some illustrations here. What you're going to do is you're going to hold the testicle in both hands. You see how the diagram is. The fingers are in the back, the thumbs are in the front, and you're just going to move it in between. And you're going to feel for any lumps or bumps. All right. Now, whilst you do this, be aware you'll have the epididymal cord that can feel like a lump or a bump. But if you do both of them, one right after the other, then you kind of get used to what that feels like. So you won't be so worried about it. All right. So if you notice any hard lumps, smooth or rounded bumps, changes in size, shape, or consistency, then you go and see your urologist right away. Now, I must say the testes aren't always symmetrical. One testicle may hang lower than the other, maybe a little bit larger than the other. That's no need to get alarmed. All right. But if it's a noticeable difference, then you go and see your urologist, because it's better for you to be safe than sorry. All right, so I've been diagnosed with cancer. Now what? All right, so first of all, I want to say that the diagnosis of cancer isn't the death sentence that it used to be, say 30 years back. Yes, it's still highly lethal, but for the most part, there's been a lot of advances in medicine. And for a lot of cancers, they've actually come a long way. So stay calm. It's the first thing. Learn as much as possible. That first visit, when you're diagnosed with cancer, you're going to be in shock. You're not going to hear much beyond the words cancer. So whatever you do, make sure you schedule a follow-up visit shortly after. You go home, you write down all the questions you may have, because when you're in that office, all of those questions that came to you at night when you were lying awake is going to escape you. So make sure you write it down. If you have someone close that you trust, maybe you can bring them on the other visit, or just ask if you could record so that you can remember what was said. All right. Learn as much as possible about the type of cancer that you've been diagnosed with. All right. Ask about follow-up tests. These tests are needed to stage a cancer. So ask about the follow-up tests. Especially here, they may not offer it because they may, especially if you're seen in the public service, the assumption may be made that you may not be able to afford it. Some of them you actually have to go away for. I know that when I had my diagnosis, a part of my staging was that I had to get a PET scan to try to see where all the cancer have gone. There is no place here. There wasn't any then, and there's none now that offer PET scan. So I had to have that done away. All right. So ask about follow-up tests. Tell them, hey, just let me know what it is I need and where are the possible places that I can go and get these tests. And then you go and you read up on it and you see if that's what's recommended. In this day, medicine is supposed to be a standard of care, meaning barring resources, what they do in the United States is supposed to be done over here. It's supposed to be done in England. All right. It's okay to get a second opinion. Now, of course, if you had to have a biopsy, you're not going to want to go and do another biopsy unless there's an issue. But definitely get copies of your results and speak to a second doctor if you want to. Ultimately, you need to feel comfortable that you're doing the right thing and you're doing the right choice. Cancer is different in different people. All right. So you need to arm yourself with all of the information. Get expert opinion. Be careful where you get your information from, because you will get a lot of information and a lot of things about what cured so-and-so's cancer and what this one did. Make sure you get your information from reliable sources. Keep the lines of communication open. Now, usually the first instinct when you get cancer, when you get the diagnosis of cancer, is you want to shut down and you want to go inside yourself. Don't. Speak with friends you can trust, speak with your family, be open and honest with your physician. If you want a second opinion and you need your results, say that. It's okay. You are entitled to a second opinion. You don't have to try to go around it because you think, oh, he's going to get mad. He's not going to give me my results, so I have to tell him this. No, you're entitled to a second opinion. So go ahead. As a matter of fact, you can even ask for recommendations for a second opinion if you trust your physician. If not, if you have physician friends that you know, then you can ask them. Okay. But it's important to keep the lines of communication open. I'll say here too, along that line, sometimes when you hear the diagnosis of cancer, people automatically assume it's a death sentence. If they indicate that it may be far gone, you may not want to hear everything. If you do not want to hear everything, if there's only so much you want to know, just tell me, doc, what I need to do. I don't need to know this. I don't need to know that. You can say that, but make sure you have somebody else, another family or relative or friend who can go and the doctor can speak to on your behalf so that they can give them the information. And this is a reliable person who's going to be checking out options for you to make sure that you, in consultation with your doctor, that you choose the right path for you. All right, I will tell you, when I was initially diagnosed and my doctor said, okay, this is the treatment I want you to do. I want you to go ahead and have the mastectomy. I was like, okay, no, I don't want to do that. I don't want to do radiation. This is what I want to do. And so he was like, why? So I told him why. So he's like, okay, that's fine. So that's what I did. Doesn't mean that you cannot change your mind later, because after a year and I went for my follow-up MRI. I was diagnosed with breast cancer. I went for my follow-up MRI. And when I called for the result, it was like, oh, we saw something. We need to have a discussion with some other people down, all of the anxiety and everything came back. And I was like, well, if this is how it's going to be, then you know what? I'm just going to go ahead and do the mastectomy. And when I told my doctor that again, she said, wait, hold on, we've done this and this is what's going on. Let's wait for these results. And I said, no, if every time I do this, if there's a suspicion, then, I would rather just do the mastectomy and get it over and done with. And he said, okay. So it's okay to make your decisions, but make sure your decisions are well informed. All right, anticipate possible physical changes. All right, and this would include changes in your appearance. If you have to do chemotherapy, chemotherapy just kills cells that are dividing rapidly. It does not discriminate. So yes, cancer cells divide rapidly, but yeah, you have other cells in your body that also have a high turnover rate. So that would be things like your skin and its appendages. So you would lose your hair. The cells in your GI tract also turn over rapidly. So you would have problems keeping food down. You're going to be vomiting. You're going to lose weight. So just anticipate the possible physical changes and speak to your doctor about it. Okay, which chemotherapy or which treatment are we going to be doing? What are some of the side effects? What should I expect from that? If I'm going to do radiation, will I get burned? I remember when I first started my chemotherapy, I had to have a port place, which is a little device they put underneath your skin because the chemotherapy actually has to go inside the vein. So that goes into a vein. But I had no idea. So most of my clothes were a little bit below where that was. So, for the first 2 weeks, I was walking around with this big bulge showing about my clothing because that was not something that I anticipated. So make sure you talk to people who've had cancer, particularly the type of cancer you've had, find support groups so that you can anticipate what changes you can expect. Also anticipate changes in what you'll be able to do. Chemotherapy, if you have to do chemotherapy, is very draining. Radiation therapy is very painful. All right. So you may have to make allowances at work. I know for my chemotherapy, at that time, I worked in the hospital. I had a hectic schedule. I was still doing 24-hour calls. But at that time, I was like, if I have a complication, then I have to take time off. So let me just see if I can go through it with the chemotherapy. But when I realized how draining the chemotherapy was, what I would do was the day after I did my call, I would go for my chemotherapy and then I would just have my hours of sleep after that, which helped from the call and also from the chemotherapy. But these are things that you have to anticipate. Line up practical and personal help. I said already that this is the time you want to go into yourself, you want to reflect, don't, all right? Allow people to help you. You're going to need the help. If people are willing to do errands for you, allow them to do it. If they're willing to go grocery shopping for you, allow them to do it. You may need someone to drop you to and from getting your chemotherapy because you may be too tired afterwards. It's okay to accept help. All right. Don't shun it. Even if you're a person who used to do things for everybody else, now's your time. Let people do things for you. Take care of yourself. Take care of your emotions. Take care of your psychological state. Take care of yourself. All right. Don't get caught up in depression. Take care of yourself. Try as best as you can to maintain your normal lifestyle. All right. Because when you act the sick role, your body tends to follow. All right. Not only was I diagnosed with cancer, but you will remember that Chris also had cancer. Actually, the year after I was first diagnosed and I went to get my follow-up MRI, him and Chriselle were waiting for me and he actually fainted. Ended up in the hospital. They did tests and realized that he too had cancer. All right, so he was treated, and then he had surgery. His wound didn't heal right away, so he had to have his wound packed. This all happened whilst we were away in the States. So when we came back, classes resumed, and I had spoken to his doctor, and I said, I think he needs to go back to work, because Chris is a man who loves to work. He loves his job. And I knew just being home alone in the bed was not going to do anything for his psychological situation. So he went back to work. He was doubled over when he went back to work, to the point that his boss said to him, I need a letter saying it's okay for you to come back to work. But that helped with his healing, because it helped with his psychological state. All right. When you're home by yourself, all kind of thoughts creep into your head. Why me? Oh, I don't want to do this. Oh, poor me. And then all of those negative chemicals are released inside your body, and they actually affect your healing. So try to keep a positive output. If you can maintain your normal lifestyle, do. If you need to stop and take a break, do. Okay. Do not over push yourself. All right. This is a good time to review your goals and priorities. I know sometimes you just get caught up in life and living, that we don't take time to reflect and to see what's really important. Brother Kevin preached a sermon on Sunday. We said that it was better from Ecclesiastes, where he said it's better to go to the house of death, of house of mourning, than of joy, because the living will reflect. So, use this time to reflect and to reorganize yourself. And then you have to develop your own coping strategies. All right. So no one can tell you, this is what you should do. Oh, you shouldn't go to work. Oh, you shouldn't do this. You shouldn't read. You shouldn't talk to people who have cancer because they're going to depress you. You have to develop your own coping strategies. Yes, find a community who can support you. And we have the sister association over here who helps people journey with cancer, not just breast cancer. So that it's important to find a community of people who've gone through what you've gone through, but it's also important to find your own coping strategies. All right, hold on to your faith and stay positive. All right, so that's the most important thing. Stay positive. Okay, so I said a lot. So I'm going to open up the floor for questions. I specifically did not go into treatment, because the different types of cancer will require different types of treatment. Not only that, it depends on what stage you're at, and a stage is just a system to determine how far your cancer have spread, usually from 1 to 4, with the lower numbers being the better numbers. Okay, so the higher the numbers are, the worse it is in terms of how far the cancer have gone. All right, so are there any questions?
Vanessa Clark.
Good afternoon. Good night. Can you hear me?
Yeah, I can hear you.
Okay. I wanted to say 2 things. Something you touched on, which was very important. When you're dealing with your health, you have to take control of your own health, because sometimes you go to a lot of these doctors and they want to dictate to you certain things. And then when you have questions and you ask them certain things, like they have this one-track mind about things. You say, but what about this? Let me suggest this. And they believe, because they're the doctors, that you shouldn't have nothing to say because they have more experience and knowledge than you have. And I found it personally, and I found that, the situation, my sister too, because she had a fibrotic breast for a long time, and we had spoke about it, and I told her, you should get it cut off, because you don't know what it might in the future, how it might affect you or whatever. And the doctor said, no, you don't need to get it cut off, da 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 da, whatever. And guess what? That's how I said it. It's the thing that came right back around. Years later. So I'm just saying that certain times, like, I agree with you that you have to research stuff, but a lot of times you have a lot of doctors, and not every doctor. Because they're the one that study, like, you don't know why you saying this, because I'm a doctor, I'm in the medical school, and so sometimes a lot of people, like I say, a doctor, I feel like you respect it more. So when you stood up and say, look here, this is what I'm doing, this is not what I'm doing, they're not going to look at you the same way they can look at me, who is not a medical professional, you know? So I mean, some you know how things work. People like us, the normal people like us, they're not going to take us as seriously as they would take you. You know, and that's what I want to say. But that's a good point. You have to be in control of your own and stand. And you have to stand with them. No, this is not what I want. This is what I want. And like I say, I've had personal experiences where when a doctor told me, "Oh, you have a lot of opinions." And I said, "But excuse me, this is my body. I have opinions." So that's what I'm saying. So it depends, but that's what I want to say. That's a good idea. And I think too, one of the other things that I wanted to say too is that I had a friend. I think diagnosing stuff in the Bahamas, I feel like it's a challenge for a lot of, not only because of the equipment and stuff. Because I had a friend, her husband, for 2 years, he had cancer. They did not know, and they kept sending the physiotherapy and this and come to find out, he just got tired of it. And he said, "Man, something is not right." And just last year, they carried him to the U.S. They found that he had cancer in the muscle of his leg. I'm saying all these years, he's been a physiotherapist. So I found a diagnosing things in the Bahamas is telling us maybe why the important that you said. Always and a third opinion if you have to, in order to safeguard, because sometimes you get a first opinion that it end up being something worse. Yeah, excellent presentation.
Okay, so you were in and out, but I think I got the gist of what you were saying. To the point about sometimes the doctors don't listen. What I would encourage you to do is to make sure when you go armed with your information. Now, have I had colleagues who've complained, oh, they went to Dr. Google and this and that? I was like, well, no, that's a good thing. You have patients who want to be informed, you know, and once you present yourself that, you know, this is my body, I have done the research, this is what I find, what do you think about this? And they see that you've done the research, then a good doctor, and I'm saying a good doctor because that depends on your bedside manners, will take that into consideration and will explain to you, well, hey, yes, I see your point, but I disagree because of this. But if that's your treatment, because you have the right to your own treatment. If you refuse what they're offering, then you refuse what they're offering. Now, if you refuse what they're offering, can they say, okay, this is what I'm offering. You know, if you don't really want to do this, this is what I think is best for you, then I won't do that. You know, they may not agree with what you want to do. They may not go ahead and do what you want to do, especially if what you want to do is outside the standard of care, then yes, they can refuse that. But once you show that you have an interest and you've read it and you know this is what you want to do, they cannot make you do what you do not want to do. You have the right to refuse any and all treatment that's being offered. And you have the right to see somebody else as well if that doctor feels that, hey, you know, this relationship isn't working for us, perhaps you need to see another doctor, then you have that right as well. All right. So that's the first thing. With regards to your friend, I could see why if he'd been having bony pains, they would go ahead and just send him there, because common things are common, and sometimes they just assume that what's common is what's going on. But a rule that they should abide by is, hey, if you've tried this and it didn't work, then maybe you need to have another look at something else just to make sure that we're not missing something. All right. So if you've been going to the doctor for a problem that they have not identified and they've been doing the same thing over and over again, but you're not getting any relief, then you have the right as a patient to say, hey, we've been doing this. Why don't we look and see if there's something else? And for the most part, a lot of doctors are afraid of litigation. So if you come right out and say, hey, you know, this isn't working, I want to do this, unless it's something that has more harm than benefit, they're going to go ahead and do it, right? So feel free to speak up is what I'm saying. Just because they're the doctor does not mean that you have to accept what they say. But I'm saying that whilst I'm also saying to you that you find your information from reliable sources and then you go to them with that. Don't just go oh, I saw on WhatsApp somebody send me this and they said if I hang from the tree and swing 3 times, my cancer is going to go away. So just tell me what tree I should swing from. You understand? It has to be reasonable. And if you have something reasonable that a route that you want to take, most doctors will say, okay, you know, I see that. I think we should go this way because this and this, but if you insist, we can do this. Or if they feel that, no, that's too detrimental, you know, and that goes way beyond what the standard of care is, I cannot do that. You have the right to refuse their treatment. And they also have the right to say, no, I think this is more harmful to you than beneficial. So I cannot do this. And then you can perhaps see if you can find another doctor.
All right, thank you. Oh, another question. We relates to colon cancer. Why is it so difficult to detect colon cancer?
So colon cancer actually isn't one of the more difficult ones to detect. You can do screening. We don't have a national screening protocol in place for colon cancer, but some physicians do it, especially if you ask for it and you're over 50, or if you're younger than 50, but you have risk factors. So you can do fecal occult blood, which is a simple test. You just stool in a cup and take it to the lab and they look for blood, and that's a warning sign. Or you can actually do the sigmoidoscopy or the colonoscopy, where they put a tube in you. It's very uncomfortable and a lot of people don't like it. And perhaps that's why a lot of people aren't too keen on getting it done. But when they do that, they actually put in a scope and camera into your colon, and they're looking at the lining of the colon to see if there are anything that's any visible changes. If there is, they can actually take that out at the same time and biopsy it, send it to the lab to have a look at it.
So I asked that question because I think we had a friend that she died.
You went out, Vanessa.
Oh, because there was a friend that we had who kind of died of colon cancer. They said he said he had no symptoms at all. He said he had basically nothing until they found out that basically he was on that bed. But he had no symptoms whatsoever. Nothing that showed him that something was going on. So that's why I asked, is it because of lack of symptoms with that disease, or it functions a little differently than the other cancers, or I'm just asking.
So, like I said, most cancers in their early stages, you won't have any symptoms. With colon cancer, you tend to have bleeding. You tend to have bleeding in the stools, right? So it's not necessarily when you wipe, but it's mixed with the stools. Bleeding and mucus, like coli in the stool. So you actually have to be paying attention when you pass. A lot of people don't. So if that sign is there, yes, they would miss it. All right. Sometimes you have changes in your bowel pattern, like you would have been one who passes at 12 o'clock every day, like clockwork. And then suddenly you're missing 2, 3, 4 days. And then the next day you just passing 5 or 6 times a day, you know. So you may not, you may notice that, but not think anything of it. And then another common symptom you would have is you may start to feel tired because you bleed from those cancers, but you just attribute it to other things. What I'm trying to say is sometimes the symptoms are subtle, all right? So sometimes you don't pay attention to it, which most people do, that's okay. But, and if you're not going for yearly physicals, because for instance, if you went to the doctor last year, they did your blood check, your hemoglobin was 15, but now this year it's 11, they can say, hey, wait a minute, something's wrong. And then they can ask you specifically and ask you to look for those symptoms. But a lot of times as Bohemians, we don't go to doctors when we're well. We wait until we're sick. And sometimes we wait until we're too far gone. Now, having said that, it is possible that he may not have had anything until he started to lose weight and then he realized that something was wrong. So colon cancer is another cancer that you can actually be screened for. Like I said, it's not on our national screening program, but if you ask your physician, well, in the private service, I know they'll be happy to assist you. If you request it in the public service, they may actually send you privately to have it done, simply because I don't think they have enough resources to be doing colonoscopy as a general screening tool in the public service.
Mr. Curry, you have 3 hands.
Okay. You can let me know who.
Okay, we have Mike And there is SZTT, RG, and Lincoln Young. Let's go Michael Sealy first, and SZ.
Good afternoon, Dr. Curry. Some of it was answered. I was going to ask about the colonoscopy. It was recommended that men should look at doing that test, because men really do refrain from having testing done. I think compared to women will go and get testing quicker than men. But I hear inside the discussion a little while ago about some of the colonoscopy. But men at a certain age, would you recommend it?
Yes, so definitely, if you can afford to have it done and you're 50 or older, then it's a good screening tool. If you have a history of colon cancer or rectal cancer, then you probably should start your screening earlier. I would agree with you that men are a little bit more reluctant to go for physicals than women, and this is just routine physicals, and a lot of men do not enjoy the idea of having a whole tube pass up their colon, even though they kind of put you to sleep when they do it. But yes, and some countries have it on their national screening program, but in the public center, I don't think that they have the resources to be able to do it, and that's probably why it's not on the screen, on the public screening, the national screening program.
As well as would hemorrhoid or men's training also result in, I guess they could say, in blood and stool and things of that nature?
Yes, definitely. Definitely. So a lot of cancer symptoms are subtle and they mimic other symptoms in the body. And that's how come a lot of times they get missed. Like Vanessa spoke about her friend who had back pain and was going for physiotherapy because they probably thought it was some spinal issue and came to find out he may have had bony cancer. So a lot of the symptoms mimic other symptoms in the body. So if you have something that's persistent, if you having blood in your stools, then that's definitely something that you need to get checked out. All right. If you're having bleeding from hemorrhoids, you will have blood on top of your stools, and when you wipe, you will get blood on the toilet paper. So that kind of helps to let you know exactly where along the track you're bleeding. If you're having bleeding in your small intestines, a lot of digestion goes on there. So what you would end up with is black tarry stools. If you have blood in your lower intestines, but not right down to the rectum, then what's going to happen is that the blood is going to be mixed with the stools and you would have some mucus there too. And then when you have hemorrhoids or bleeding right by the anal area or the rectum, you have the blood on top of the stools because the stools are coming out. And as they're coming out, you have the bleeding. So it goes on top of the stools. And when you wipe, you would see blood on the stools. So pay attention to your stools, guys. I know it's not something that people find a particularly enjoyable activity, but pay attention to what you put in the toilet and what goes on the toilet paper.
All right. There's a name that I can't pronounce. It's SZTTBRG.
That's me. I'm Burge. I want to ask this related to the HPV vaccine.
Mm-hmm.
Yes. I heard you said that at a certain age that it wouldn't make sense that you get the HPV vaccine. Why would a doctor still recommend someone over 45 years to get the HPV vaccine? Or is it something new, something else new that comes out?
Okay, so there actually is a newest vaccine. The HPV vaccine that we give in the public sector, we call it Gardasil 4 because it protects against 4 strains of the HPV virus. There are lots of different strains. The Gardasil 9, which a lot of them use privately, protect against 9 strains. That's why it's called 9. Some physicians are of the view that they say, okay, well, yeah, I know more than likely you have been exposed to these strains, but maybe you have not been exposed to these other strains yet, and maybe it will still confer some benefit. And so on that ground, they would recommend it. But when they do that, because it's actually approved for use, basically up to 26, some of them up to 45. When they do it beyond that, they're using it off label. And when it's no, there's no problem per se with using medications off label. But when you do, you just have to explain that to the patient, especially if they're going to be paying for it. You need to say, well, hey, at this age, most people already have HPV, but I don't know, maybe, and the situation is unique too, because if you have someone who's 46 and a virgin, but planning on getting married soon, then it would benefit them, right? So it depends on the situation, but in either case, then that's something that they need to discuss with them to let them know what the limitations are of that, and that, we're doing it outside the regular age. But I feel that it will be beneficial for you now because.
Okay, thank you very much.
No problem.
Lincoln Young.
Yes, so thank you. Good evening, Dr. Curry. Thank you for a very, very excellent presentation. I knew why a lot of things were done in terms of caring for and diagnosing cancers and the things to look for, but only in medical terms. And so it did not make common sense to me. But after hearing you this evening, I'm able to put the reason to the things being done. So I appreciate that. I appreciate also you putting the experience of your personal family of dealing with cancer, because I believe that does a lot for individuals who are hearing you say, keep the faith and stay positive. I'm hearing that come from you, who is one who have been down that road. I think helps a lot. Now to the questions. The first one is you mentioned that radiation is one of the risk factors, and mentioned that CT scans and such like pose a threat to some extent in that regard. I've heard for many years that things like microwaves may be contributing to the high cancer rate. Do you know that's factual or fictional? And if so, then to what limit and regard that may be? And the second question is this: that you also mentioned about the hereditary nature of many of the cancers. I'm just wondering if you have noticed, and it's been recognized among physicians, an increase in new cases in families without the predecessors necessarily having a cancer background. And if you're noticing those new cases, which ones of those are the ones more frequently recognized?
Okay, so thank you for your comments. Let me start with your last question first. So in terms of cancer and familiarity, most of the cases of cancer occur in people with no family history of cancer. So yes, there's a small subset of cancers that are hereditary, but a lot of the cancers occur from new mutations, meaning that there was something going on with your genetic material that caused it to malfunction, that caused you to get the cancer. Let's take, for instance, breast cancer. Everybody knows that there's hereditary component to breast cancer. And the Bahamas itself, we have one of the highest rates of BRCA gene in the world. But yet, most of our breast cancers, 75% of our breast cancers are in women who have no family history of breast cancer. So yes, there's a hereditary component, but that is not a factor as the individual component, meaning that a lot of cancers arise from new mutations. So it's recognized around the world that most of the cancers are in people who have no family history of cancer. That was your first question. That was your last question. Your first question, remind me of your first question, please.
Microwaves and
microwaves. Right. So in terms of microwaves itself, so far there's no conclusive evidence that says yes, microwave cause cancer. They feel that the amount of the electromagnetic radiation that comes from the microwave is a little bit too small. And additionally, very few people would stand directly in front of the microwave whilst they're microwaving their food. A lot of people just move and go. So I cannot say that it absolutely does not, but right now, the jury is still out on that. All right. And you had a third question?
No, that was the extent of it. Thank you very much.
Okay, you're welcome.
Dr. Curry, can I just speak to the colonoscopy?
Go ahead.
I know that some persons may feel a little funny about having one, but I can tell you that I know I've had one before, and they do put you to sleep. You do not know what is happening. I did not feel anything at all. In fact, when I woke up, I was asking them, when you're going to do this? And they said, we finished. There's absolutely no side effects afterwards. You feel no pain or anything afterwards, and you don't feel any pain during it because you're sleeping. The most unpleasant thing about it is the preparation that is required up front. And that is you're required to cleanse your bowels. That's how everything that's inside you got to come out. And so there's a process of drinking a lot of liquids and different preparations that they give you. And that is perhaps the most unpleasant thing. But even that, I would not say is unpleasant. As Bahamians, we all know our mom used to give us something to clean us out. So all of this is the doctor gives you something to clean you out. And he wants, when you go to heaven, you clean. And so that's it. So I would encourage you, if you can, to get one and make sure, screen against it. It is preventable. I can't remember on that chart that you showed, if it is, that was 100%, right?
So, no, it was 53.4%.
Okay.
Yeah.
Yes.
All right, so I have a comment from Paulette Mackey in the chat. It says, can routine blood work show cancer present? So it depends on which cancer. So definitely cancer of the bone marrow or cancer of the blood cells. Yes, you would see that. They also have blood tests for specific cancer markers. So they have one for prostate cancer, but that's not unique to prostate cancer, like I mentioned earlier. That could actually be elevated when you're having an infection of the prostate gland or when you have your gland enlarged. They have one for ovarian cancer. So, but the ovarian test and the PSA, PSA may be routine because it's part of the National Cancer Screening Program. So you can find out for some cancers from your blood work. Additionally, you may have hints that something's wrong. For instance, if you have colon cancer and you're bleeding out, it may not even be noticeable bleeding, but bleeding for a prolonged period of time, that would drop what people loosely call the iron level or the hemoglobin. So you would know, because remember these cancers, they invade into the blood vessels and they can cause bleeding. So you would know that something's wrong.
I see Michael Seeley.
Yes, once again, Dr. Curry, I know, like I say, people probably would like to know, and then they don't want to know. It's like almost like a mixed feelings, because when patients find out, I believe it will be even, for some people, they go in a shell, like you saying, don't do it, but, and so, we always hear that early detection is good. I could understand you have opportunity to, get treatment and all this, but once again, right back to, I guess some people are afraid to know. And once again, what would you encourage people, who probably going through this, wanting to know and then still afraid to know, mixed feelings?
Right. So yes, and we see that a lot of time. Sometimes people are in denial, and so you would see people finally present with masses that are huge, and you wonder, how could you have lived with that? And they're only there because somebody say, no, this got to stop. You need to go to the doctor, and drag them to the doctor. And then of course, by that time, whatever you could have done, the time has already passed. So if you're out there, if you felt a lump in your breast, please go get it checked out, because like I said, the earlier we catch it, if we can get it before it moves to other organ systems, there's a better chance of us treating it, and there's a better chance that you would have a good outcome. So, I know you're afraid, but it's better to know, and you can deal with it head on. All right, so don't hesitate. Go ahead, make your appointment, and go ahead and get tested. All
Can I
right.
see a hand? You have a hand.
I want to make a comment from the chat. Gwen Seeley mentioned that there's a special going on now for colonoscopy. I guess she can put in the chat where. And then from Landy Laroda, he asks, good night, Dr. Curry, would you recommend persons with cancer to take this COVID vaccine? Okay, so if you have cancer and you're actively undergoing chemotherapy, then no, because your immune system is compromised. All right. You're already in a position where you're prone to all kinds of infections. So no, I would not recommend it. I would actually tell you to just try to, as much as possible, stay isolated. So you're in one of those high-risk categories because your immune system is compromised at this time. If you're in a stage where you're not actively taking chemotherapy, but maybe you're just taking hormonal therapy, then sure, discuss it with your doctor. And I think it should be safe. Again, COVID vaccine is pretty new. Information is just coming out. So go ahead and have that conversation with your oncologist and with your primary care physician. And they would evaluate your risks versus benefit. Ultimately, that's what medicine is about, risk versus benefit, because nothing is totally benign without side effects, and nothing is totally without risk. So everything is a balance. Oh, he said he didn't ask that. Someone sent it to him. Okay, sorry. And Gwen says she will get out the information about the colonoscopy and send it to us. All right, you said there was another hand?
There are two hands, Reverend and Sam, if I'm pronouncing that correctly.
Good afternoon, everybody. Derek Bullard here. Doc, very, very, very good. Very, very good presentation. I really enjoyed it. Mine is pretty quick. Technology is moving at extremely high rate, and before long, we don't need to go through any other physical examination. I've already had a lot of new technology that's sent to me and another doctor where you can use your phone to scan your whole body like you would do a complete scan at the hospital. And it lists everything that's going on in your body. It'll show every issue you have, from cancer to blood pressure, the bone marrows, everything, the brain. It's just amazing. So the colonoscopy, we wouldn't have even do the colonoscopy by going to sleep, etc. You just put it to your body and it just literally lights your body up through the phone. You'll see everything being mentioned, list out. You'll see all of the calculation, the percentages, the whole works. So technology is moving very fast, everybody, and it's only a matter of time now before they give it to the doctors themselves to use for their own private practice. I just thought I'd mention that. Thank you, Doc. Very good lesson.
Thank you, and I hope for that day, but right now, it's not here yet. And even for the different types of cancer, you use different screening device. So for the colonoscopy, you actually use an X-ray when the colon goes on. When the colonoscope goes into your colon, they have a camera there and they project the images onto the screen. For some cancers, you use ultrasound. For some cancers, you use CT scan. For some cancers, you use MRI. So I look for the day when they can find one device that will be able to detect everything. And then some cancers are detected from blood tests. So I look for that day.
Yeah, this device actually does that. Every last one of them, all of those different names you call out. It does, because like I said, it was given to a doctor who sent also to my phone, and he was showing me how it really is. Every kind of scan you can imagine, this thing does. Thank you, guys.
No problem. Okay. Who's
Sam
next?
Pinder, Denise Penelope.
Hi, good evening. Dr. Curry, really truly appreciate your presentation this evening. Very comprehensive and informative, as usual. Good evening to all. I'm just kind of following up on something Mike said in his last comments about the apprehension, the concerns that individuals would have in really seeking help or early diagnosis. I guess because of fear, trepidation. You know, particularly for people of faith. And I know as human beings, there's a natural fear that we would have because of the great unknown. You know, we think when we hear certain things like cancer and HIV or AIDS and certain things that we hear, it's like a death sentence. You know, when I was diagnosed recently, my doctor was like, "Oh, you know," and when he saw my reaction, it's like, "What's happening with you?" I said, "Well, you know, where do we go from here?" You know, and when he spoke with my sister, she had to remind him, because she knew him, that I'm a man of faith. You know, I told a brother recently, all of us, when we were born, God gave us two things. He gave us an expiration date, and he gave us a one-way ticket. You know, one of them, we don't have a choice. The other one, we do. All right. So there's no need to fear anything in this life. I don't, because God controls everything. All right. Ultimately, everything is in his hands. All right. Whether we're here or whether we are there, he's in control. That's my faith. And I want to encourage particularly those of us who are of the household of faith to just take on that attitude that the Father that we serve, he is more than able to bring us through whatever, you know. Just that are risky. Jumping on a plane, just jumping in your car to go to work. That could be your final moments. You know what I mean? Nobody knows how, when, or where the end will come. You know, so it's a matter of facing each day with attitude of gratitude for that particular day, because that's all you have. You know, all of the other things, just leave it to him, man. You know, just leave it to him. There's nothing we can do about. Now, the quality of life is one thing, preparing for old age and all that sort of thing. But, you know, Proverbs 19:21 said, "Many are the plans in a man's heart, but it's the counsel or the purpose of the Lord that's going to prevail." Nobody knows what God has in store, what happened. I don't know where it's going to go. I'm hoping it goes in a certain direction, but God knows, and wherever it goes, I'm at peace. I'm happy because I serve an awesome God, and he has my best interests at heart, and I know that he loves and cares for all of us. We just need to trust him. You know, just that's my 5 cents to that point. And I know I understand the concerns that we all have. We have this life, and some of us believe that's all we have. But there's more to life than this life. Amen.
Thank you, Sam. True words were never spoken.
Amen.
Thank you so much.
Good night, Dr. Curry.
Good night.
I missed some of your presentation, so forgive me if you already answered this question. As you know, I have a family history of cancer. My mother, all her sisters, my sister, my father, and all his sisters, they died from cancer. And now my mother's brother has prostate cancer. I did the BRAC test a few years back, and it showed that I did not have the gene. So I just wanted to know, how often should I take that test? Do I need to take it again or what?
So no, it's a genetic test once it was done properly. Now, I must say, where did you do it? Did you do it in Florida?
I did it in Arkansas.
Okay, all right. So the thing about that gene is that there are different mutations of the gene. I think they had a study with a university in Florida to see which mutations we have. You know, in the Bahamas, a lot with family, you know, there's a lot of close breeding, I guess. And so the gene has been compounded. So because there are different mutations of the gene, and you did it in Arkansas, I don't know what mutations they test for, but it's very expensive to try to test for all of the mutations. So what they usually do is they test for the most common ones in the community. So if you have the opportunity to go to Florida and test for it again, then that may, you may opt to do that. Was your mommy tested? Was your sister tested? Because if they were tested and they got their mutation, it would be easier for you to look for that particular mutation, easier and cheaper.
Okay, thank you. I don't think they were tested though, but I, you know, so.
Okay, so I would just recommend that you go ahead and you keep up with your annual mammogram,
Yeah.
and you specifically pay attention to your monthly self-exams.
Okay, thanks.
No problem. Are there any more questions? Okay, well, I do appreciate the attention of my audience. I thank you so much, Sam, for those final words. And so I guess I'm going to turn it over to Brother Dean so that he can close out.
Yes, thank you once again. You blew it out of the park. We truly appreciate this session. As you noted, we went over time. Usually we don't. And tonight was a resounding success. We had some 86 persons on the Zoom platform at one point, the highest level that we've had since we've been running these sessions. And so we wish to thank each and every one of you for joining us. We recognize that the majority of persons on this site are indeed visitors. These sessions are being facilitated by the Highbury Park Church of Christ. And we, as I said earlier, these sessions are held on the final Thursday in each month at 7:30. And so the person or persons that would have invited you out, we ask that you stay in contact with them for information on our next session. Dr. Curry would have advised that on our next session, we will be dealing with prostate cancer. And we will have as our facilitator noted urologist, Dr. Gregory Pinto. I think most persons know Dr. Pinto. He is a very popular doctor these days. You may have heard him on the radio. So we encourage you to tune in. Also have your family, your friends, and everybody who has a prostate to tune into that presentation next month. We anticipate that we will have a successful presentation because it is a problem that impacts the lives of a significant number of men. And no doubt all of us know somebody at one point in their life that would have experienced prostate cancer. And the following month, we will then tackle breast cancer, and we will provide additional information on that next month at the end of the session. I wish to invite Deacon Mike Seeley to close us out in a word of prayer at this time.
Let's go to our Heavenly Father in prayer. Father God, we thank you for this night. We thank you, oh God, for this informative, Father, session that we had. We thank you for all the participants who are here. We pray, oh God, that with this information, oh God, that we could better prepare and assess ourselves, and Father, that we would use this information, that we could help family members and friends. And Father, we would go and seek help if we need help, oh Father, as we know, God, that you are our ultimate help. You are the great physician. You have our lives in your hand. And so, Father, as we continue, oh God, to live this life, Father, we know, God, that you're able to keep us. But, oh Father, we take it not for granted to know that you have given us doctors. Father, you have given them wisdom and knowledge. Father, we thank you for the knowledge and all that was imparted tonight. Father, I ask that we may continue, oh God, to be people who look after our health. And we hear some things that we need to do, Father. We know eating and exercising and doing all these other, some of the simple things, Father, they help. And so, God, I pray, oh God, that everyone here, Father, that they have been encouraged and been motivated. Father, as we part this place but not present, Father, may you continue to be with us. And as we look forward, oh God, to our part 2, Father, help us to tell more individuals, and we'll have another lively and prerogative as we encourage and as we continue to gain and glean more about our bodies and the things that we may come into contact with. But oh God, once again, bless us and keep us and watch over us until our next appointed time. We just say thank you. In Jesus' name we pray. Amen.
All right, as you leave, would you just say good night? And we again, we appreciate you attending. Good night, everybody.
Good night.
Good night. Thank you very much.
Good night, everybody.
Good night, all. Thank you for coming.
Good night.
Good night, everybody.
Good night.
Good night, everyone. Dr. Curry.
Good night.
Good night, all.
Good night.
Good night.
Good night.
Good night.
Good night. Thank you, Dr. Peter Curry.
You're welcome. Thank you for coming.
Good night.
Good night.
Good night.
Good night.
Good night. Thanks, Doc.
Good night. No problem.
Good night.
Good night. Thank you. Good night.
How are you trying to get her?
No problem.